Imagine this: a simple blood test could significantly cut your risk of dying from prostate cancer. That's the promise of PSA screening. But it's not that simple. For years, experts have debated whether the benefits of PSA screening outweigh the potential harms. Now, a landmark 23-year study is adding crucial new evidence to the discussion. The European Randomized Study of Screening for Prostate Cancer, ERSPC, a massive, multinational trial, has just released its final, long-term findings in the New England Journal of Medicine. This research offers compelling data on the long-term effects of PSA screening, revealing that it does reduce prostate cancer deaths and improve the balance between benefits and risks. But here's where it gets controversial. The study also highlights the potential for overdiagnosis and overtreatment, meaning some men might undergo unnecessary biopsies and treatments for cancers that would never have caused them harm. The core of the debate: balancing early detection with potential harms. As men age, prostate health becomes a common concern. The challenge lies in finding a screening approach that catches aggressive cancers early without subjecting men to unnecessary interventions. Prostate-specific antigen (PSA) testing offers a way to detect prostate cancer sooner, but its use has been a hot topic for years. The reason? PSA levels can be elevated for reasons other than cancer, leading to false positives, anxiety, and invasive biopsies. Furthermore, some prostate cancers are slow-growing and may never pose a threat to a man's life, yet their detection can lead to aggressive treatments with potentially debilitating side effects like impotence and incontinence. And this is the part most people miss. With increasing life expectancies, the risk of developing and dying from prostate cancer is projected to rise globally. Healthcare systems are therefore grappling with how to best allocate resources to address this growing challenge, weighing the benefits of reducing mortality against the potential for decreased quality of life and the costs associated with widespread screening. The ultimate goal is to refine screening strategies to target those who truly benefit while minimizing unnecessary tests and treatments for others. How the ERSPC study was conducted. The ERSPC study was a large-scale, randomized trial conducted across 8 European countries. Researchers focused on men aged 55 to 69, randomly assigning them to one of two groups. One group received repeated PSA testing with predefined triggers for biopsy, while the other, the control group, did not receive invitations for screening. The screening process involved standardized PSA tests, with most centers inviting men for testing every 4 years. However, there were variations in screening intervals across countries, with Sweden and France inviting men every 2 years and Belgium every 7 years. A PSA level of 3.0 nanograms per milliliter was generally used as the threshold for recommending a biopsy, although some countries also used additional tests like digital rectal exams or free-to-total PSA ratios when results were borderline. Let's be clear, this was a meticulously designed study intended to give definitive answers. What the researchers measured. The primary goal of the study was to determine whether PSA screening reduced prostate cancer mortality. This was carefully assessed by blinded local committees using a standardized algorithm, with an international committee resolving any disagreements. Secondary outcomes included the overall incidence of prostate cancer, the incidence of cancer based on European Association of Urology, EAU, risk categories, low, intermediate, high, and the incidence of advanced disease, defined as cancer that had spread to lymph nodes or bones, or a PSA level greater than 100 nanograms per milliliter. The statistical approach, rigor and nuance. The researchers used sophisticated statistical methods to analyze the data, following what's known as intention-to-screen principles. This means that everyone who was assigned to the screening group was included in the analysis, regardless of whether they actually underwent screening. They used Poisson regression to estimate rate ratios, not risk ratios, and accounted for deaths from other causes using competing risk methods. Absolute risk differences, the number needed to invite for screening to prevent 1 death, and the number needed to diagnose to prevent 1 death were calculated using a technique called bootstrap resampling. To account for variations across different centers and the effects of non-attendance, they also performed sensitivity analyses. The clinical severity of the cancers was documented using tumor node metastasis, TNM, staging, Gleason scoring, and PSA levels. Notably, data from French centers were excluded from the primary analysis due to low participation rates and biopsy compliance. The bottom line: mortality reduction and screening efficacy. After a median follow-up of 23 years, the study found that prostate cancer mortality was 1.4% in the screening group compared to 1.6% in the control group, representing a 13% relative reduction in mortality. This translates to an absolute risk reduction of 0.22%. In practical terms, this means that inviting 456 men to screening prevented 1 death from prostate cancer, and diagnosing 12 cases of prostate cancer prevented 1 death. It's important to note that mortality from other causes was nearly identical in both groups, approximately 49%, highlighting that overall life expectancy plays a significant role in determining the net benefit of screening. Earlier detection, earlier stage cancers. While screening led to a higher overall incidence of prostate cancer, rate ratio, 1.30, this was largely due to the detection of more low-risk tumors. The rate ratios for low-risk, intermediate risk, high-risk, and advanced disease were 2.14, 1.10, 0.95, and 0.66, respectively. This suggests that screening effectively shifts cancer detection towards earlier stages, reducing the likelihood of late-stage presentations. Compliance, biopsies, and diagnostic yield. The study showed high compliance with screening, with 83% of invited men attending at least 1 round of screening. Of these, 28% had at least 1 positive PSA test, and 89% underwent biopsy after a positive result. However, only about 1 in 4 biopsies, approximately 24%, confirmed the presence of cancer. This highlights the potential for screening to increase the number of procedures and diagnoses that may not ultimately alter individual outcomes. Analyses adjusted for non-attendance showed a slightly larger benefit from screening, rate ratio, 0.84, suggesting that the primary intention to treat estimates may have underestimated the true benefit. Consistency across centers and long-term durability. The results remained consistent even when including data from French centers with shorter follow-up periods. However, center-specific differences in screening intervals and biopsy compliance contributed to some observed heterogeneity. Importantly, the mortality benefit of screening persisted long after screening ceased, particularly among men who reached the protocol's upper age limit without a cancer diagnosis. However, this benefit diminished over time, suggesting that the effectiveness of screening may decrease in older men with significant competing health risks. Putting the ERSPC results in context, comparison with other trials. To fully understand the implications of the ERSPC findings, it's crucial to compare them with other major prostate cancer screening trials, such as the US PLCO trial and the UK CAP trial. The US PLCO trial was hampered by significant contamination of the control arm, with many men in the control group undergoing opportunistic PSA testing. This made it difficult to detect a clear difference between the screening and control groups. However, modeling studies suggest that with less contamination, the PLCO results would have been consistent with a 27 to 32% reduction in mortality. The UK CAP trial, on the other hand, involved a single invitation for screening and achieved only modest participation rates. As a result, it showed only a small absolute reduction in deaths. These comparisons highlight the importance of repeated, protocolized testing with high engagement in order to translate early detection into fewer deaths while minimizing unnecessary harms. The harm-benefit ratio improves over time. Interestingly, the study found that the harm-benefit ratio of PSA screening improved over time. At 23 years, the absolute mortality reduction increased from 0.16% at 16 years to 0.22%, while the excess incidence of prostate cancer decreased from 31 to 27 per 1,000 men. This suggests that the longer the follow-up period, the more favorable the balance between the benefits and harms of screening becomes. The future of prostate cancer screening, risk-based and individualized approaches. The ERSPC study provides strong evidence that long-term, Protocolized PSA screening can reduce deaths from prostate cancer.